Good morning. Can you all hear me all right? Waiting for a yes. It shows that it's working on my computer. We only have 7 people in the room. That's interesting. We have 8 now. Okay. All right, I'm getting a text. Okay. I'm going to go ahead and get started. I'm going to assume that you can hear me. If somebody could type in that they can hear me, that would be great. Or if somebody could just let me know, can you hear me this morning or not? Can you all hear me? Can you all hear the instructor? Okay. I need to hear from somebody. If you could type in that you can hear me, I can see where people have joined the room. Okay. Could you all type in if you can hear me talking? Yes. Thank you, Carrie Ann. Okay. Not sure what's going on with the... Okay, now I see yeses. All right. So we're going to go ahead and get started. We did talk about the transphenodal approach to remove a tumor. And let me back up just a little bit. We talked about the pre-op care. So now we're into this is a rerun. But what I want to rerun is the assess for diabetes insipidus on your client. And that is important to do. And it's transient. So it may occur because of the loss of antidiuretic hormone, which is stored in the posterior lobe of the pituitary gland, or it could be due to cerebral edema because they worked on the pituitary during surgery. So the notes that I want you to take down are that when you assess for transient diabetes insipidus that can occur after the transphenodal surgery, you want to closely monitor the patient's urine output, their serum, and their urine osmolarity. And we'll talk later about the management of that. But remember, with diabetes insipidus, that is the syndrome of PPP. So you expect your urine output to be high. You would expect the urine osmolarity to be low, and you would expect the serum osmolarity to be high. Okay? So I just wanted to reiterate that. Okay, home care. If a hypophysectomy was performed or the pituitary gland was damaged, hormone therapy will be necessary. And here we're talking about ADH, cortisol, and thyroid hormone replacement will be needed. They could have permanent loss or deficiency in FSH and LH, and this could lead to decreased fertility. And in that situation, you would have to help the client work through the process. And if the hormones are prescribed, just a minute, that could be a student calling in. Hello? Okay, no it's not. Sorry about that. Just remember that they need to be aware of that it's a lifelong treatment and that they cannot stop taking their medication. If they have acromegaly, they are at higher risk for colon polyps and colorectal cancer. So those who were treated and they had acromegaly, then they will have to have a screening colonoscopy every 3 to 4 years instead of your typical 10 years. Okay, now we're talking about excess of trophic hormones. And we're talking about hyperfunction of the pituitary gland, and it's related to the excess production of the trophic hormones. And when that happens, it results in excess hormones from the target organ. So for an example, If their adrenal corticotrophic hormone, ACTH, is increased, and it sends a message to the adrenal cortex to produce more corticosteroid hormones, and now predominantly we're talking about the cortisol and the glucocorticoid, then they're going to have Cushing's disease. And that would be manifested by the moon face, fat deposit on the trunk areas, fragile skin, which we'll talk about later. If there is excess of TSH that goes to the thyroid and tells the thyroid to make more T3 and T4, then we'll have the condition of hyperthyroidism. Prolactinomas, they are prolactin-secreting adenomas that account for 40 to 60% of hyperfunctioning pituitary tumors, and this is noted in your book. It results in gynecological problems in females and decreased libido and impotence in males, and they also could have visual disturbances. And the way they treat that is with a dopamine agonist, and that would be Parlodel that we talked about earlier. And they may require surgical treatment depending on the size and the extent of the tumor. And then we're not going to talk about hypofunction of the pituitary gland. It is a rare disorder. The end result is a in-organ failure. And again, the usual cause would be a pituitary tumor or destruction of the pituitary gland. And you'll be deficient of all your anterior pituitary hormones. And so there would be deficiency of TSH and ACTH, which are life-threatening. And then hypovolemic shock due to the sodium and the water depletion. And that's all I'm going to cover on that. And it tells you what the treatment is as far as lifelong replacement of medications. And we're going to switch gear to what is more common, and that is disorders of ADH secretion. And in this situation, you should be able to tell me what SIADH is, syndrome of inappropriate diabetic hormone, and then diabetes insipidus, and that is the syndrome of PPP, and SIDH is the syndrome of NOP. Okay. Now, ADH synthesized in the hypothalamus. We know that there is a medication that is synthetic ADH called vasopressin, arpitressin, and we know that ADH is stored and secreted by the posterior pituitary. It regulates water and sodium balance. And the way that it affects sodium is if you hold on to too much water, then you dilute down your sodium and you have a dilutional hyponatremia. We know the direct effect ADH has when it's released is it tells the kidney tubules to hold on to water, and what is filtered is returned to the circuit and restores blood volume. Okay, diabetes insipidus, we know that this is syndrome of PPP, and there is a decreased production of ADH is one cause. Or it could be a decreased renal response to ADH. So again, this is a rerun from what I taped earlier, but I feel like it would be beneficial. So central diabetes insipidus is caused by an organic lesion of the hypothalamus or the posterior pituitary. It could be caused by head trauma, cranial surgery, or a central nervous system infection. And we're talking about affecting the central nervous system, whether it's any of these that we just discussed, that would be a central cause. And you would recognize that would mean that there's a decreased production of ADH, so a deficiency. Nephrogenic, you know, nephron is the functioning unit of the kidney. And so nephrogenic diabetes insipidus means that the renals are not responsive to the action of the ADH on the distal tubules. So again, you don't have the desired effect you want of holding on to water. And so that is a common cause of nephrogenic. Another common cause is if a psychiatric patient is on the drug lithium, it can cause the renals to be less responsive to the action of ADH, and they are perpetually thirsty and can get into a big problem with dilutional hyponatremia from drinking so much water, and can go in the other direction, but that's nephrogenic. And then dysprogenic is a structural lesion located in the thirst center, and they have a psychogenic polydipsia, which we are not even going to go there on that one, so if you want to mark that out, I won't ask any questions about dysprogenic. Okay, symptoms of diabetes insipidus. Here you're very concerned about fluid status. They have an increased thirst called polydipsia. They can drink up to 2 to 20 liters of water a day trying to replace lost volume. And they have an increased urine output, polyuria, and again it could be 5 to 20 liters a day. They have very dilute urine with a very low specific gravity, so you know it would be less than 1.005. They have nocturia from interrupted sleep because they have to get up to the bathroom so much. You would anticipate the serum osmolarity, of course, would be greater than 295 because they are high and dry. They are very weak from lack of sleep and from the fluid volume deficit. And let's see what our next slide shows. Their central nervous system symptoms would show from the loss of fluid, mental dullness, irritability. They have weight loss. Due to the dehydration, the results would be hypotension, weight loss, tachycardia. If it continues to progress and is not treated, they could go into hypovolemic shock and circulatory failure. Now, when central diabetes insipidus occurs as a result of head trauma, it is usually self-limiting and it improves with treatment. If central diabetes insipidus is caused by a tumor, the treatment would be hypophysectomy. Okay, now we're into diagnostic tests, and here we're talking about okay, we're talking about diagnosis. Okay, because there are 3 classifications of diabetes insipidus, diagnosis will depend on identification of the cause first. And we talked about what was central and what was nephrogenic. Central involving the central nervous system, nephrogenic involving the kidneys. So they could present as fluid volume deficit. We said that. Main diagnostics is water deprivation tests. So prior to testing, you would assess their baseline weight, their vital signs, their serum and urine osmolarity, and their specific gravity of urine. And that should be in your book here, so I'm doing this from my notes, but it should be in the book on how to diagnose diabetes. Here it is. It's on page 1195. Okay. So we already said what we would do prior to. Okay, the patient is deprived of water for 8 to 12 hours. So what we're doing is we're imposing dehydration. Then they are given desmopressin acetate, which is synthetic antidiuretic hormone, desmopressin acetate, or DDAVP. They're giving it sub-Q or nasally to the client. This is after they're imposed 8 to 12 hours of no water. Patients who have central diabetes insipidus exhibit a dramatic increase in urine osmolarity from 100 to 600 osmos and a significant decrease in urine volume. That is because, what did we do? We gave them the ADH that they were missing, and then the body responds by producing, by holding on to fluid, and so their osmolarity in the urine is going to go up because they'll have more solutes. And they will have a significant decrease in urine volume because you just gave them ADH. Okay? Now, the patient with nephrogenic diabetes insipidus will not be able to increase the urine osmolarity to greater than 300. So there is, because remember, we are giving ADH, but in this situation, the distal tubules are only going to respond partially to the ADH because they have decreased sensitivity. So they will not have as good a response. Okay? Now, your book also mentions that the test continues until urine osmolarity stabilizes. They also say if their orthostatic hypotension develops, they will stop. The patient, of course, then is given, now this is, they held their fluid for 8 to 12 hours, and they check their urine osmolarity, and they check their weight, and then they check their blood pressure, and then they give them the DDAVP, and then the urine osmolarity is checked in 1 hour. And again, with central diabetes insipidus, that osmolarity is going to rise after the vasopressin is given quickly. It's going to rise slowly with nephrogenic and not get as high as the other because of the decreased responsiveness of the kidney. Does that make sense to you all? It's a little complex, but you can reason it out. Any questions on that? Yes, no? Okay, I'm assuming since no one's, let's see. So no, you don't understand it? Okay, well, we're going to cover it again because I do want you to understand it. Okay, this person is, okay, Lauren has yes. Will said he came in late. Okay, so we do need to rerun this. Okay, this client is suffering from diabetes insipidus, but we don't know if the cause is from the central nervous system, which is central diabetes insipidus. Or could it be nephrogenic diabetes insipidus due to decreased responsiveness of the tubules to the release of ADH? So in central, I have a question for you. If it's central is the cause, is there any ADH being released? No, that is correct. Okay. If the cause is nephrogenic diabetes insipidus, is ADH being released? So if the cause is nephrogenic DI, is the ADH released? Yes, it is released. But when it gets to the distal tubules, they are not responsive to what the ADH is telling it to do. Okay? Does that make sense? So when we do the water deprivation test, they are doing it to distinguish between, is this person having diabetes insipidus? We know they are because they are PPPing. Their urine osmolarity is low. Their urine specific gravity is low. Their serum osmolarity is high and dry. They're PPPing too much. Okay? So what they will do to either person, we got to find out what's the cause. They will withhold their fluids anywhere, the book says, from 8 to 12 hours. Another resource I found said 8 to 16 hours. But the purpose that you want to understand for water deprivation is we are going to invoke or impose dehydration more than what they had, trying to distinguish what's going on. So they'll assess their blood pressure, their weight, their urine osmolarity before they start the procedure to see where they're at. They'll check their urine osmolarity with this imposed dehydration to see if it changes, and they'll check their blood pressure. And the book doesn't say anything about weight loss. I got that from another source, so don't worry about that one. But what they will do is when they see their blood pressure dropping or they have orthostatic blood pressure changes, they say the urine osmolarity is staying about the same now. They're going to give them the synthetic antidiuretic hormone, and that's desmopressin acetate, DDAVP, subcutaneously or nasally. Okay, if the problem is central diabetes insipidus, would you expect there to be a quick response to the ADH that's now being given to this patient? And would you expect to see the serum osmolarity go down, the urine output pick up, the urine osmolarity will go up, and the urine specific gravity will go up? Would you expect that if we had a central DI cause? So what do y'all think? The answer is yes. Because if we said the cause was lack of ADH because the central nervous system is not producing the ADH and sending it to the kidney, and we give them ADH, we're going to get a quick response. You're going to see the osmolarity of the urine go up, okay, quickly. Does that make sense? you're going to see urine output pick up dramatically. Does that make sense to you all? Because we gave synthetic ADH. Okay. Now, if it is nephrogenic DI, we know that the renals in this situation, the distal tubules, are less responsive to the ADH that is sent out by the posterior pituitary. Therefore, we will see a response from the synthetic antidiuretic hormone, but it will be a blunted response because of the decreased sensitivity of the nephrons. So you will see an osmolarity rise in the urine, but not as high as with a central DI. Okay? Does that make sense? Now I'm not going to ask you the differences between the two. What I want you to know is, why are they doing a water deprivation test? Okay? Well, we already know that they have diabetes insipidus from the symptoms that they have presented with, but we want to know, is it central diabetes insipidus or is it nephrogenic? Does that make sense? And you want to know, what are we watching for? What is the effective outcome of this test by the ADH that you're giving? What's the expected difference? Oh, my screen just went out. Okay. Will, do you mean the expected difference between the two? Okay, the difference, I think that's what you're asking. Okay. The difference between the two, if somebody has central diabetes insipidus, you're going to see a dramatic increase, and this is out of your book on page 1195. You're going to see dramatic increase in the urine osmolarity because they're not going to be peeing as much, so they're going to have more concentrated urine. You're going to see an increase in their urine-specific gravity, again, because they're not making as much urine. But when it's nephrogenic diabetes insipidus, the response is going to be cut in half. Does that make sense? Did I answer your question, Will? Okay, I don't see a response. It could be something with my system. I'm going to assume that you understood that, so and we'll move on. But if not, let me know. Okay, now we're going to talk about treatment. And then treatment is completely geared towards maintaining fluid and electrolyte balance. Okay? And we know that with acute diabetes insipidus, we're going to manage it with oral fluids and IV fluids because, remember, this person is vascularly dry because they're in the syndrome of PPP. So again, treatment is geared towards maintaining fluid and electrolyte balance, also geared towards hormone replacement, okay? Now, the drug of choice for replacement is desmopressin acetate, and that's that synthetic ADH. And it can be taken by nasal spray, oral route, IV, or IM. And other hormone replacements are aqueous vasopressin, which I had mentioned earlier, and our lysine vasopressin. So if you see the term vasopressin, you should be thinking ADH, ADH, okay? And that is how we are going to manage central DI. Okay, so for central DI, just to review, the treatment is geared towards maintaining fluid and electrolyte balance. We will give them oral and IV fluids. We will treat them with hormone replacement. The drug of choice is desmopressin acetate, or DDAVP, and you see the word pressin in it. You know that it's talking about synthetic antidiuretic hormone. Now, nephrogenic diabetes insipidus is treated differently, because we said the kidney is not as responsive to the ADH. So this client, we would treat them with a low sodium diet and thiazide diuretics. Thiazide diuretics slow down the glomerular filtration rate. When you slow down the ability of the glomerular filtration rate, it allows more time for urine to be reabsorbed in the loop of Henle and the distal tubules. So again, to treat nephrogenic diabetes insipidus, we've got to treat where the problem is. We have a less responsive nephron unit. So we've got to affect glomerular filtration rate. So it's treated with a low sodium diet and thiazide diuretics, and the generic for that is hydrochlorothiazide, or HCTZ. Thiazide slowed down the glomerular filtration rate, allowing more urine to be reabsorbed in the loop of Henle and the distal tubules, and the effect is a net decrease in urine output. Remember, those distal nephrons are the most sensitive to ADH. So we're slowing things down to promote reabsorption of fluid, and so they'll make less urine. If this is not effective, the low sodium diet and the thiazides, doctors have prescribed Indocin, which is an NSAID, to help increase renal responsiveness to ADH. Okay? Now, we'll get back to the slide that's in front of you. We're talking about treatment for medication. We said you would self-administer, and you might want to add on the screen, it does say PO and intranasal, but you also can give synthetic ADH, the IV route or IM, but most common when the patient's going home will be PO or intranasal. You would teach them to assess for overdosage. So if I overdosed on ADH, why would I have a headache? And why would I have nausea and water intoxication? And we're talking about predominantly central, but it could be with either if they go home on this medication. This is central diabetes insipidus. I'm going home on PO or intranasal synthetic ADH, which is your desmopressin. You have to teach the client to assess for symptoms of overdose, and you tell them that could be a headache, that could be nausea, that could be water intoxication. Why, if they overdosed on ADH, do they have this problem? This is a really easy question. Can somebody type in? Is it a hard question? I'm just misunderstanding this. If I give a person ADH, it's an antidiuretic hormone, what are they holding on to? Is anybody out there? Okay, I'm waiting. This is frustrating. If they are giving them ADH, they are holding on to what? Come on, guys. Perhaps you're typing in responses and I'm just not seeing them. But I'm hoping that you're typing in that they're holding on to fluid. If they overdose on ADH, they are holding on to too much fluid. With the increased circulating volume, that's going to cause central nervous system irritation, so they will have a headache. It'll irritate the system so bad they'll get nauseated, and then they'll develop a problem with water intoxication, and they will have a dilute sodium. Okay, adverse side effects of you using the nasal, you know, anytime you use a nasal, just a minute, this might be a student. Hello? Yes? Oh, I opened it up because people have been charting. Okay, let me. All right, that is weird. How come people were able to do it? Okay, chat and permission is back on again. I don't know why it turned itself off. Sorry about that. I was getting frustrated. Okay, thank you so much. Bye. Okay, someone try to type and see if I can see it now. Dee just let me know that chat permission for some reason had been turned off. See if you can type something in now. Although you all were typing earlier, that's weird. Okay, I apologize. So you all do know the answer. Thank you, Dee. Okay. If you want to say what is the expected positive outcome of administering the desmopressin, you would say that you will see the urine output do what? Go down, correct, correct. And you would expect their urine-specific gravity to do what? What's their urine-specific gravity going to do? Go up. So I have poor effect on here. That means if their urine-specific gravity doesn't respond, then that is showing that the medication is not effective. And if their urine output does not go down, then we've got a poor response and something's going on. And of course, it's important for them to follow up with their physician. Okay, is this making sense now that we can talk to one another? Okay, thank you so much, and I apologize because I was starting to get my uproar in a wad there. Okay, here we're talking about the treatment of nephrogenic. It's a rerun because I got ahead of myself a while ago. Again, we said if you know the cause is in the distal tubules and the nephrons there, then we're going to treat them with a low-sodium diet. We're going to give them thiazide diuretics to slow down glomerular filtration rate, to give the lupohenol and the distal tubules time to reabsorb fluid and make less urine. We also might give the patient a non-steroidal anti-inflammatory drug like Motrin or Indocin. And Indocin is the generic. Okay, so we just talked about syndrome of PP. Now we're going in the other direction. So SIADH is the syndrome of inappropriate release of ADH. So you've got to memorize that. It's the syndrome of inappropriate release of ADH. So that means that it shouldn't be released. We don't have a elevated serum osmolarity. We don't have a reason for it to come out. We don't have a problem with their sodium. So you want to memorize that for sure, and then the other term for it is syndrome of no P. So here, ADH is just being sent out by the posterior pituitary down to the distal tubules, regardless of what our serum osmolarity is. Most commonly seen in the older adult. It results in fluid retention. It results in dilutional hyponatremia. And remember, chloride is married to sodium, so your chloride would also be low. Okay? And the most common cause of SIDH is small cell lung cancer or some type of malignancy. It also could be caused by head trauma or influence of drugs. But if the situation when it's caused by head trauma or influence of drugs, it's self-limiting and it can be managed. Now, if they have a malignancy, they will have chronic SIADH. Now, the reason that a malignancy can cause SIADH is the fact that cancer cells produce ADH, they store ADH, and they release ADH, which I think is kind of interesting. So that is why, again, the most common cause of SIADH is small cell lung cancer or some other malignancy because of the fact that cancer cells produce ADH, store ADH, and release ADH. We also said another cause could be head trauma or the influence of certain drugs that affect the release of ADH inappropriately. In that situation, we said it's a self-limiting condition that can be managed. Now, if it is chronic SIADH due to malignancy, then it's going to be an ongoing problem. And we're rerunning again that if you release too much ADH inappropriately, the end result is going to be the distal tubules will reabsorb fluid and make less urine, so you will have fluid retention, a dilutional hyponatremia. Your serum osmolarity will go up or down. Down. That is correct. That is correct. What will be your urine serum osmolarity? what will be your urine osmolarity and your urine specific gravity? Okay. Yeah. Your urine osmolarity will go up and your urine specific gravity will go up. That is correct. So just be alert to the signs and symptoms, again, of hyponatremia. Okay? So make sure that you're aware of that. Let me see if we cover that in the next one. No, we don't. So we're going to go back to hyponatremia. Okay. Excess ADH makes the distal tubules of the kidney more permeable, meaning easy for stuff to move back in, and the result is more water reabsorption takes place. As the extracellular fluid volume expands, urine output decreases, the patient gains weight, the sodium levels decrease. Remember, with hyponatremia, they're going to complain of muscle cramps and weakness. We know the expected level of sodium is what? If the person is healthy. 135, correct. 135 to 145. And remember, some places will say 134 to 146, but 135 to 145. Remember, as the serum sodium continues to fall, the symptoms of the central nervous system are going to become more severe. Okay? So as the sodium drops to around 125, you'll start to see problems with confusion. Does that make sense? Very irritable. They may complain of nausea. Now their abdomen is cramping. Then you may see muscle twitching. As it keeps drifting down, they will become lethargic. As it drifts down more to 120, 115, you can see seizures, and they can become stuporous, where it'll be hard to arouse them. If it falls enough, they will go into a comatose state. So what is happening here in the brain that is causing them to have these central nervous system effects from the low sodium? Okay, we have a dilutional hyponatremia. So the fluid is going to go where? If I have hypotonic vascular fluid going on, because I have dilute, no, cells are not shrinking. If I have hypotonic fluid circulating in my plasma, my serum osmolarity is low, then I have less osmose and more solution. So I'm hypotonic. So remember, fluids are going to follow the solute trail. So where is the solutes at if they're not in the fluid space, the vascular space? Where's this? Inside the cell, correct, Will? So you have intracellular shift into the cells of the brain. The end result is cerebral edema. Does that make sense? Yes, swelling. That's correct. So they're going to make the diagnosis, and I hope that's on the next slide. Okay. Oh, this is what I was just covering. There's your excess secretion of ADH. There's your weight gain. There's your sodium levels falling. And then there's the cerebral edema. And Tara puts, oh, duh. That's okay. If this stuff can be complex if you haven't thought about it a lot. And so, that's okay. Okay. Now here are symptoms of SIDH that we already talked about. And notice the central nervous involvement with the muscle cramps, abdominal cramps, muscle twitching, anorexia, confusion. Definitely if they drop below 120, you're going to see severe confusion. But you can see it starting at 125. And of course, we said it can progress from there. Okay, diagnosis is made by measuring the serum osmolarity and the urine osmolarity. Okay, and they'll look at the serum sodium. So you would anticipate if it's a dilutional hyponatremia, the sodium is going to be less than the 134. Your serum osmolarity is going to be less than 280 because you're holding on to fluid.
your urine-specific gravity is going to be greater than 1.005. What do you think about the BUN and hematocrit and the hemoglobin? What are they going to do? Go down, correct, because of hemodilution, okay? Treatment, our whole treatment is geared towards two things. First, we're going to restore normal fluid volume, and by doing that, the net effect will be we're going to restore the serum osmolarity. Does that make sense? So if the sodium is slightly decreased, say it's around 125 to 132 and they have some symptoms, which you would just restrict fluids, okay? And you will see them tell you that this person can only have 800 to 1,000 milliliters a day of fluid, and that's in 24 hours. Do you see how that might be hard for a patient to adhere to? But if you do some thorough teaching about sodium and teach the family, if it's a self-limiting problem, this is what we're going to do to get that sodium to come back up. We're going to restrict fluids. Does that make sense? Yes. Okay. Now, if the sodium is less than 120 and they have acute neurological symptoms, the doctor may order 3%, and the book still says that, but I will tell you that it's unusual to see that ordered anymore. Typically, you'll see normal saline given and fluid restrictions. Now, if the doctor chooses to give 3%, tell me, well, it tells you there, it's a hypertonic. But can you imagine how much hypertonic this is if it's 3% normal saline? Does that make sense how serious that is? You have a super hypertonic. Now tell me what's going to happen to the cells of the brain if you give this a little too fast. What's going to happen to the cells of the brain is shrink. Oh yeah, they'll shrink, they'll burst. they'll shrink so bad they'll defrag, yes. So that's why I'm telling you, if you ever see an order for it, please, please, please check with pharmacy. Make sure of the rate. Check the patient very closely because the brain does not tolerate rapid fluid shifts. And unfortunately, I'm telling you this from experience because back in the 80s, and I remember these things so acutely because I was fairly new to the ICU then, a fairly new resident ordered 3% normal saline. This is before we had all the safeguards on pharmacy. He ordered the rate too fast. The nurse taking care of the patient had only been in the ICU for about 8 months. She had only been out of school 2 years. She did not consult another nurse. She ran the 3% at the rate the physician ordered for 2 hours. Again, the rate was too fast. The patient became confused. The patient became lethargic. And, of course, we called the physician. And when we ran in the room to help her, we caught the fact that the 3% was running, and we stopped it. But it caused significant brain damage to the patient to the point that we sent them to a nursing home in a vegetative state. And it was very frightening because usually you see it ran at a really slow rate, like, 20 cc's an hour, something like that. But this was like at, I think, 75 or 100, and it ran for 2 or 3 hours before it was caught that there was problems. So just be aware of if you give it, it's got to be given really slow, and everybody is checked and made sure, is this appropriate to give to this patient at this time, or should we just go with full strength normal saline and restrict fluids and maybe give a diuretic? But the diuretic is only given when the sodium is at least 125. And then we are aware of, we're going to have to supplement with potassium if we give a diuretic. Yes, 3% is 3 times that of normal saline. So if you see 0.9, normal saline. That's the equivalent to our plasma. And if you give someone 3%, it's 3 times the normal concentration of salt in that fluid. Does that make sense? So it's really frightening if you hang it, and you've got to be really very careful. You'll never see that done out on a regular unit. Only in the ICU would you see it hung. And again, you don't see it used very often unless it's an emergency. Okay. Now, if it was a drug that stimulated the ADH release, we would stop it. And on page, there should be in your book, I think it's 12, let me find it here, 459. Well, let me find it. There should be a thing in your book that tells you the drugs that can cause it. Okay, it's on page 1193. It tells you that carbamazepine, which is Tegretol, chlorpramide, which is Diabetes, certain opioids, certain general anesthetic agents, tricyclics, SSRIs. You can see that all of these have something to do with the nervous system, central nervous system. Opioids, general anesthetics, they could cause a syndrome that's self-limiting of inappropriate release of antidiuretic hormone. So you can look at the causes in Table 53 on page 1193. Okay? Now, we can give a patient it says declamycin, but the generic is demeclocycline. It's DEMECLOCYCLINE. We can give the patient that drug and lithium together if they have chronic SIADH. The demeclocycline and the lithium block the effects of ADH on the renal tubules. And so that's why you would give it to a patient who suffers from chronic SIADH. And that is located on page 1194. You also could tell the client to use ice chips or sugarless chewing gum to help decrease their thirst. And that should be coming up. Here it is. So fluid replacement is important. Assess urine glucose and specific gravity. Intake and output, daily weights. Did I go backwards on this patient? No, I didn't. Okay. Let's add some more notes here. You need to remember that if you lose a liter of fluid, how much weight will you lose? Do y'all remember? One liter of fluid equals 1 kilogram of weight loss. So that would be 2.2 pounds. So nursing care, know who's at risk, which we already talked about those clients that could be at risk for developing it. Assess if they have a low urine output. Why do they have a low urine output? Assess their urine-specific gravity. You would expect it to be what if they're in this syndrome of inappropriate release of ADH? What would their urine-specific gravity be? Yes, yes, that is correct. Very good. So you would instruct them on the reason they're on a fluid restriction, and we expect the fluid restriction to be approximately what? How low are we going to go on fluid restriction? And they're not going to like it. Yes, Will's right, 800 to 1,000 milliliters a day. So are they going to complain of thirst? We take away a lot of the fluid? Yeah. So we're going to offer them ice chips, but you're going to have to be careful with those. How many people know that patients can cheat with ice chips? To measure ice chips, and you all need to write this down and remember it, it's half when it melts. So if I give somebody an ounce of ice chips, when it melts, it's really only half that if you want to measure it for intake. So did y'all know that? So typically an ounce is how many milliliters? 30, correct. So if I told you somebody was getting could have 100 milliliters of free fluid an hour, and the rest of it would be on the tray, and they wanted to take a lot of ice chips, if they took in 2 ounces of ice chips, how much really water would they have taken in? If it's 2 ounces. Yeah, then they would have taken in 1 ounce. So just remember that. If you're calculating intake, that's going to be different if they have ice chips versus if they just drank water. Okay, very good. Mercedes said 30, that's correct. If you're going to give them diuretics, you'll teach them about that. And what electrolyte are you concerned about if you give them diuretics that you have to keep an eye on? Potassium, that's correct. Remember, potassium supplements, the K-Dur, has to be taken with food because it can cause GI distress. You want to teach your patient the signs and symptoms of electrolyte imbalance. Predominantly, you're going to teach them about sodium. You will teach them about K too, but mainly they're going to present with a problem with their sodium. So teach them those signs and symptoms. Teach them about the medication they're going to take for chronic SIDH, and that is the dimeclocycline and the lithium. Now, these both can be nephrotoxic, so they're going to have regularly renal panel done. So they're going to have to check their BUN and their creatinine and their GFR at regular intervals to make sure that renal function is preserved. And they can tend to suffer from fungal infections if they're on this medication. Teach your client to be alert to suddenly urine output dropping. Be alert to a sudden weight gain without edema. Okay? So and then teach them drugs to avoid if they have chronic SIDH. Should they be taking opioids or any kind of central nervous system drugs if they have chronic SIDH, or should they avoid them? Right, no, they should not. Okay. Okay, any questions about this? And then I'm going to load the thyroid content. So I'm going to go ahead and load it. So let me get out of here and put the thyroid in. And while you all are thinking, if someone wants to run to the bathroom and come back, I do not blame you. Okay. There's thyroid. So it should start loading. So we're switching gears to thyroid. And I need to find my notes on thyroid. Okay. Okay, and we're going to start on page 1195. Okay, the thyroid has loaded. And it looks like we still can talk, so that's good. Okay, we're going to talk about goiter, which means an enlargement of the thyroid. We're going to talk about thyroiditis, which is an inflamed condition of the thyroid. We're going to talk about hypothyroidism and hyperthyroidism. Okay, goiter is mentioned on page 1195, and it is an enlargement of the thyroid gland where the thyroid cells are stimulated to grow, which when that happens, here's the thing. It either can cause an overactive thyroid, because now you got all these thyroid cells cranking out T3 and T4, or it could stun the thyroid and cause an underactive thyroid, which is hypothyroidism, and that's where the gland's not getting enough T3, T4, and it'll start to enlarge because of it. So you could see a goiter with either one. And goiters can be toxic or non-toxic. And let me look through my notes and see if I wrote anything important about that you would need to know. Okay. A non-toxic goiter is not associated with overproduction of thyroid hormone. So non-toxic, that is mainly due to a deficient iodine in the diet. And you see that in other countries, but you don't see it here anymore that I know of. Okay. So the most common cause and worldwide is a lack of iodine in the diet. And that's, in America, we do use iodized salt. So in our country, the goiter is more often due to an overproduction or an underproduction of thyroid hormones or to nodules that have developed in the gland itself. And there it talks about a non-toxic goiter is a diffuse enlargement of the thyroid gland that does not result from a malignancy or an inflammatory process. And then nodular goiters are those that secrete thyroid hormone T3 and T4 independent of any TSH stimulation. And my sister just had that surgery because she had, they said, teeny tiny nodules. They counted 40 when they had her in surgery. Her thyroid was 3 times bigger than the normal size. And she went into thyroid storm before she had surgery, and they had to calm down the thyroid before they could operate. But all these little nodules were secreting T3 and T4 regardless of what the TSH was. So you think about it, it's kind of scary. And she had difficulty with her vocal cords and difficulty swallowing because of the enlargement of the thyroid on the trachea. And then if these nodules are associated with hyperthyroidism, they're called toxic nodule goiters. You most commonly see these in Graves' disease, which is what my sister was afflicted with. Although she didn't have as bad the exophthalmos as some people do when they have that. So you're going to assess their TSH level and you're going to assess their T4 levels because we told you earlier that T3 is most plentiful, but T4 is the most potent. It affects 8% of women, 2% of men. You can have primary hypothyroidism just due to aging process, so it's a benign thing when it happens. So in primary hypothyroidism, there is destruction of the thyroid tissue or defective hormone synthesis. And secondary hypothyroidism is pituitary disease with decreased TSH being released. Let me look at my notes and make sure we're not missing anything here. Okay. With thyroiditis, it's a secondary cause. If they need iodine, we know out in the other world we take care of it. Another thing that I did not mention with hypothyroidism, we talked about Graves' disease. Okay. Another hyper person, Lordy mercy, the person has hypothyroidism. They develop it after their gland fails from Hashimoto's. So with Graves' disease, they have hyperthyroid problem, but as it progresses, the gland is destroyed. So we'll talk more about that when we get to it. Okay. And the treatment, of course, is if they are lacking thyroid hormones, we're going to give it to them. If the problem is they're producing too much thyroid, then we're going to remove the thyroid gland. Okay? Okay. Thyroiditis, it's an inflammatory process, an enlargement of the thyroid. They do have hyperthyroidism, but it is limited, and that's on page 1196. It's usually due to a bacterial fungal infection. It has abrupt onset. This is a little bit different from the other thyroid problems. Here they complain of pain localized in the thyroid or radiating to adjacent structures. They may have fever, chills, sweat, and fatigue. Okay. The most common that I have seen in America of hypothyroid goiters in the United States is Hashimoto's syndrome, and my youngin suffers from Hashimoto's. It's a chronic autoimmune thyroiditis where the thyroid gland attacks itself. And it results eventually in hypothyroidism caused by destruction of the thyroid tissue by the antibodies. And it's most commonly seen in the female gender and white ethnicity. And the goiter is the hallmark of Hashimoto's, and it develops gradually or rapidly. And the thyroid gland will enlarge and press on structures in the neck. It can affect the tracheal and laryngeal nerves, the vocal cords. It can change the voice. They complain of sore throat, and they have difficulty breathing. And we'll talk more about that in a little bit. The main thing, though, with the Hashimoto's thyroiditis, eventually does destroy the thyroid, and they go from hyperthyroid state initially, where they have diarrhea. Then they go in the other direction as the thyroid is destroyed, and they have constipation. They have a huge weight gain with Hashimoto's when it's active, and if you check their antibody levels, they're sky high because the body is attacking the thyroid gland. And the treatment is Synthroid. It's a replacement, and it will go into remission, and a person can do fine for many years without it flaring back up. But they just have to be aware of it. They might have to have their Synthroid adjusted now and then, okay? Infections can cause, if they have an infection and that causes the thyroiditis, we treat with antibiotics. If we have to, they can do surgical incision and drainage. It tells you that T3 and T4 levels are initially elevated. We already said that early on, but become depressed with time. If it's chronic Hashimoto's, their thyroid hormone levels are usually low, and their TSH is high. Well, thyroid stimulating hormone will be high because it's trying to get the thyroid to make more T3 and T4, and if the thyroid is failed and cannot make more, then the TSH is going to continue to go up. They do see, if they give them a radioactive iodine uptake, not much is uptake when it's subacute and silent thyroiditis. And again, antithyroid antibodies are present in Hashimoto's thyroiditis. They can see recovery from acute or subacute thyroiditis in weeks or months without any treatment, watching the patient closely, giving them antibiotics. They might need a surgical incision and drainage if that's a problem. They can give them NSAIDs for the inflammatory process and salicylates, which a common one is aspirin. They can give them corticosteroids also, especially if it's a fungal infection. They might give them a beta blocker, and old-timey one would be propranolol, and a newer one would be atenolol to treat cardiovascular symptoms related to a hyperthyroid condition initially where their heart rate speeds up. And again, if they went from hyperthyroid to the hypothyroid end, they would be on Synthroid replacement. Here's where you teach them not to stop taking their medication abruptly. You tell them to notify their provider if they have difficulty breathing, swallowing, if they see swelling of the face and extremities, if they have a rapid weight gain or a rapid loss. And then the person with Hashimoto's, it's an autoimmune disorder, so you want to tell them they're at risk for developing other autoimmune diseases such as Addison's disease or pernicious anemia or Graves' disease. And we'll talk more about those disorders later. And we've already mentioned if they're hypothyroid, they would be on hormone replacement therapy with Synthroid or levothyroxine. Okay, we already talked about that. There is a higher indication of risk for thyroid cancer when you have disorders of the thyroid gland. We did not mention that. So now we're going to switch gears And I'm going to look at your all's handout and see. We've got Graves' disease. We've got drug therapy. I'm just going to make sure we're covering everything. Okay, yes we are. Okay, I just want to make sure we were. All right. Hyperthyroidism, we know that we're in a hyperthyroid state. We already said the thyroid gland is important for what? Do y'all remember when we talked about the thyroid gland? Okay, energy. Oh, amazing. That is wonderful. So as a rerun, remember, the thyroid gland regulates energy metabolism and growth and development. So if you memorize that, energy metabolism and growth and development, then you'll be able to say, oh, what symptoms you're going to see if you're in a hyperthyroid state and you're cranking out too much of this stuff. Okay? Does that make sense? We already mentioned some of the causes: Graves' disease, thyroiditis. The common thyroiditis is seen in America, unfortunately, is Hashimoto's disease. We also see Graves' disease. Now, if somebody overdosed on thyroid hormone, or if they have thyroid cancer. Okay, Graves' disease, that is the most common cause. It is autoimmune disorder. There can be exacerbations and remissions. They can get an enlarged, as you'll see the lady with exophthalmos on page 1196, and she has a pronounced goiter in her neck. And this is due to excessive thyroid hormone secretion. And women are 5 times more likely than men to develop Graves' disease. And precipitating factors could be insufficient iodine supply that's seen more out in the world. Infection and stressful life events can cause it. It can interact with genetic factors, and the person could be predisposed to have Graves' disease. And I know a family, the grandfather had it, the father had it, a daughter and a grandson all developed Graves' disease when they got older. And here's where you develop antibodies to the TSH receptor. And because of these antibodies attaching, it stimulates the thyroid gland to release T3 and T4. And then the excessive release of the thyroid hormones leads to the symptoms you see associated with thyrotoxicosis, which means we're in a hyperthyroid state. And there's the explanation here. And the body is much more sensitive to catecholamines. When they're released, they have an over-exaggerated response to the catecholamines. So if they have an exaggerated response to the catecholamines, what symptoms would the patient display that you could assess? So what would you anticipate seeing? Okay, if we got too much hyper response to catecholamines, what are you going to see? You're going to see the blood pressure do what? And the heart rate do what? Go up. Yes, there I see it. Go up. That is correct. Okay. So you have clinical signs related to 2 factors. This is a rerun. The hormones increase the metabolism going on in the body. The hormones increase the number of beta receptors. And when you increase the number of beta receptors, and now the person has dopamine or epinephrine being released, or norepinephrine being released, it's going to go hook up with these beta receptors, and there's a lot more of them, so you have increased sympathetic stimulation from the catecholamines. So the patient will have a rapid heartbeat, okay? So they'll have a tachycardia. They'll have a systolic hypertension. You palpate your thyroid and you will feel a goiter, but if it's large enough, you can see it. You can auscultate bruits over the thyroid because of the increased vascular supply, blood flow in the area. Their eyeball will protrude because it enlarges excuse me, the fat deposits behind the eye enlarge. And then there's fluid behind the eye also. And it pushes the eyeball out. So it's exophthalmos, okay? So I'm going to repeat that. A classic symptom of Graves' disease is an abnormal eye appearance, exophthalmos, protruding eyeballs. They have impaired venous drainage from the orbit. They have increased fat deposits and fluid behind the eye, and it pushes the eye forward. The eyelids become retracted because they don't change. And so they pull back and they don't close fully. So your concern for this client is now that their eyelids cannot close, what do they complain of? If your eyelids cannot completely close, well, yeah, you wouldn't sleep very good, would you? But dry eyes, yes, dryness and irritation. Also, if your eyes do not completely close, do you have full protection to blink when a substance comes towards your eye? Can you completely close your eye and blink? No, you cannot. So they have a risk of corneal ulcers. They have a risk of loss of vision. Okay? So when we talk about treatment for that in a minute, we're going to talk about protection of the eye. It's important. We already said systolic hypertension, elevated heart rate. What do you think about their appetite? Remember, we're having increased metabolic functions going on in the body like crazy. It's going to be increased. So appetite's going to be increased. They're going to be thirsty. What's their weight going to do? It's going to drop. So they're thinking, you know, wow, I can eat anything I want, and I'm not gaining any weight. In fact, I'm losing weight, and they're thirsty. What is their bowel motility going to be? Yeah, it's going to be fast. Yeah, they're going to complain of frequent liquid to loose stools. At times, they're going to have fecal incontinence if it's bad enough. They will become heat intolerant, and they will develop diaphoresis because the furnace has been turned up. Does that make sense? Okay. Now we're going to go into a problem called a thyroid storm. I've seen only 2 or 3 of those early on in my career, but it's kind of frightening when you see it. One was a family member at home. Yes, Will is right. Their central nervous system gets involved because of this hypermetabolic state, and they're twitchy and they're nervous. And my relative called and said her husband was in bed. He was complaining of being very hot, said his heart was racing, and he was scared, and he got confused and didn't want her to do anything. His temperature was 104 when she called me. And when I got there, he was in a very irregular, rapid heart rate when I listened that did not match his radio. And sure enough, we got him to ER. He was in a rapid atrial fib, and he was in a thyroid storm. So if you can think of it, it is called a complication of thyroid hyperfunction called thyrotoxic crisis or thyroid storm. And here's where all hyperthyroid manifestations that were already pretty high are heightened even more. And it can be life-threatening, but usually treated while death is rare. And precipitating factors that could cause someone to go into thyroid storm could be an infection, trauma, or surgery. Most of the time it is being seen, though, in individuals who have hyperthyroidism that has not been diagnosed perhaps, or maybe it was diagnosed and they were not alert to the developing symptoms. So here you would see a severe tachycardia. Their temperature could get as high as 105, very restless, agitated, as Will mentioned, twitchy. They could even develop seizures, nausea, vomiting, abdominal pain, diarrhea. They could get delirious, which was what was happening with this person. They could even go into a stuporous state where they're hard to arouse, or a comatose state where they're not rousable. Now, how do you treat it? You treat it by reducing the circulating thyroid hormones. They're being bombarded by all these hormones at once. So you're going to have to reduce those. You're going to have to reduce the fever. You're going to have to replace fluids that they're losing and try to eliminate any stressors that you see that have occurred. And it tells you it could happen to patients after having a thyroidectomy because they manipulated the thyroid gland and a bunch of hormones could have been dumped. But I've not seen that happen, but it could happen, okay? So again, we are going to reduce their circulating thyroid hormone levels by giving them medications that are called anti-thyroid drugs, PTU and Taprazole, and the generic is propylothyroxine or methimazole. And these drugs inhibit the synthesis of thyroid hormones, and they do help. So you're blocking the effect of the excessive thyroid hormone by suppressing the secretion of it. You can give them beta-adrenergic blockers, and here's where you would give them the beta blockers. Okay, atenolol is the one that is preferred, and I may be getting ahead of myself on my slides. I probably ought to look at that. But just be aware of, we're going to give them fluid replacement. We're going to give them antipyretics to reduce their fever. We're going to reduce and block the circulating thyroid hormones. So by reducing it, we can give them an antithyroid drug, but we can also block some of the effects on the heart by giving them a beta blocker, and atenolol is the one of choice. Okay. Diagnostic test. We're going to look at their TSH levels. And typically, you would see the TSH level down because they are cranking out so much T3, T4, the TSH does not have to do much, okay? You're going to look at their T4 and their T3. And that should be, diagnostics is on the bottom of page 1198. And it tells you, let me look here. Okay. To confirm the diagnosis of hyperthyroidism, again, we said decreased TSH levels and elevated T4, and that's the one that exerts the most effect on the gland, but T3 does have some involvement. And total T3 and T4 levels may be assessed, but they're not as definitive as the free T4, okay? So we could do a T3 and T4 looking at totals, or we could do the free T4, which is not bound up and is the one that has the potent effect, and it would be elevated. They also can do a test to differentiate Graves' disease from other forms of diuritis, and that's the radioactive iodine uptake test. Patient with Graves' disease show a diffuse homogeneous uptake of the iodine, sucks it right in because they're in a hyperthyroid state, but it's diffuse across the board. And a patient with thyroiditis, they have an uptake of less than 2%. So we're not going to get into that. I'm not going to ask you to interpret radioactive iodine uptake. Just be aware it can be used to differentiate the two. Treatment, we're going to block effects of the hormone and stop over-secretion. And here's where we're going to look at antithyroid drugs. And early on, they're going to treat them with propylothyroxine, which is PTU, or methimazole to inhibit synthesis of thyroid hormones. Usually they'll improve in 1 to 2 weeks. So some people have no surgery at all. We're going to suppress the thyroid by giving them these medications, okay? Usually they see improvement in their symptomology that they're displaying in 1 to 2 weeks with the antithyroid drug. They usually see good results in 4 to 8 weeks. Some patients stay on the drug for 6 months and then their problem is resolved. Some stay on it 2 years, okay? Iodine, and the one that you most hear about is SSKI. SSKI capitalized. That is saturated solution of potassium iodide. Okay, we're going to say that this patient has not responded well to the treatment to reduce their active thyroid. It has reduced, but not enough to levels they want, so they know they're going to surgery. So if they're going to surgery, we need to really suppress the thyroid. So they're going to give them SSKI. And large doses of iodine inhibit synthesis of T3 and T4, and they block release of it into the circulation. They also, SSKI, decreases vascularity prior to surgery, because you don't want to operate on a big vascular gland and cause an increased risk of hemorrhage post-op. You want to decrease the vascularity prior to surgery. So in this situation, they are going to surgery. We want to blunt the release of the T3 and the T4. So we're going to give them large doses of iodine to inhibit that, and we're decreasing vascularity. The other time you would see SSKI used was someone who came in with a thyroid storm. Then we would also use it in that situation. The thing that you want to know about SSKI, it can be very damaging to the mucous membrane, very damaging. So you do dilute it in water or juice. They must drink it through a straw. You do not want it to come in contact with their mucous membranes. Okay? And let me see if the book mentions it about the SSKI. It doesn't mention it. It tells you about it, how it works, and the therapeutic effect of it. It's not good for controlling it over time. We're saying you're only going to give it before surgery, or you're going to give it to treat a thyroid storm. And then it tells you it's available as saturated solution of potassium iodine. But I want you to make a note there in your book. You have to dilute it in water or juice. You have to sip it through a straw, okay, when you're administering it to the patient. Beta blockers, we already told you that atenolol is the most common one given to block the stimulation on the beta receptors by the catecholamine release. And LOL, that's the Low brothers. An older generation beta blocker is propranolol, Inderol. Do you know why you would not, what candidate would not take propranolol, would not be given the older generation beta blockers? They have a certain chronic problem, and you would not give them the older generation beta blocker. You'd have to give them the beta blocker, specific beta blockers, and that would be your atenolol. Anybody know who would not get it? The propranolol? No, not diabetes. If you have a person with COPD of any type, bronchitis, asthma, emphysema, and you gave them the older generation beta blocker, propranolol, it blocks, heart failure. Congestive heart failure would be a reason. But it blocks the beta cells in the lung, too. And we know if the beta cells in the lung are stimulated, you have bronchodilation, correct? So if you block the beta receptors in the lung, they have bronchoconstriction. So that's why they were non-specific beta blockers. The old ones are non-specific. They block the beta receptors in the heart, which is desirable because you want to slow down the heart rate. But if you block the beta cells in the lung, you cause bronchoconstriction. So COPDers is the biggest candidate. Yeah, they should never get the older generation beta blockers. So really, most doctors, regardless if the patient has asthma or cardiac problems, they should be prescribing atenolol. But be aware of, and this is something you want to really focus on, you don't ever give anybody with chronic COPD problems, cardiac failure, you do not give them an older generation non-specific beta blocker, which is propranolol. You give them one that's specific to the beta receptors in the heart, and that would be atenolol, and they do not affect the beta receptors in the lungs, okay? Okay, radioactive iodine therapy. Treatment of choice for non-pregnant adults to decrease the inflammatory effect of the thyroid, releasing all these thyroid hormones that's causing the hyperthyroidism. They can give radioactive iodine therapy, but it's only treatment of choice if you're not pregnant. But what it does is it damages or destroys thyroid tissue, and when it does that, it limits the hormone secretion. It can take 2 to 3 months for there to be a complete response to the radioactive iodine therapy. And so they may treat them early on with drugs until the therapy is effective. I have a sister-in-law, it did work for her. And after about 6 years, she did become hypothyroid and had to go on replacement. But for a long time, it worked just suppressing the thyroid gland without making her lose all of her thyroid hormones. It can cause dryness of the mouth and throat. Again, it may result in post-treatment hypothyroidism, which we'll talk about in a little bit. And then surgical intervention, that would be a subtotal thyroidectomy. They remove approximately 90% of the tissue. They will tell patients that 10% of the thyroid can regenerate. I've known a lot of people who've had thyroidectomies, and most of them I have known, it did not regenerate enough to replace their T3 and T4, and they had to go on Synthroid replacement. But I've known a few who the thyroid did regenerate, and it started producing the T3 and T4 in appropriate amounts, and they were okay, and they were called euthyroid, which is EU thyroid, meaning everything was okay. So they don't remove the entire gland unless they have to. Now, my sister, they had to remove all of hers. So treatment is only if the patient is unresponsive to drug therapy, the patient was unable to have radioactive iodine, the patient has a large goiter causing compression on adjacent structures like the trachea and the larynx, the patient has thyroid cancer. Prior to surgery, we want to decrease vascularization of the gland. We want to decrease the risk of hemorrhage post-op. So you would anticipate that you would give probably SSKI. You would give an antithyroid drug like the PTU or the Tepazole. You would give beta-specific blockers. And all of these are to minimize the symptoms of the hyperthyroid state and decrease vascularity of the gland to minimize post-op hemorrhage. All right, nutritional therapy, hypermetabolism needs are evident because they're cranking out like crazy. The furnace is turned way up. So they're going to need a high-calorie diet, as high as 4,000 to 5,000 calories a day. 6 meals with snacks, high protein, high carb, minerals, and of course they may need supplemental vitamins, but if they could get the thiamine and the B6 and the vitamin A and vitamin C in their diet, that would be preferred. Now, why would you tell them to avoid highly seasoned or high fiber during this time? They're hyperthyroid. We haven't fixed the problem. Yeah. You want to slow their gut down, so if you give them highly seasoned or high fiber, it's going to speed up the gut, isn't it? So since the GI tract is already irritated, you're not going to give them high seasoned or high fiber food because it's just going to irritate the gut more and they're going to have more diarrhea. You want caffeine-free beverages to minimize sleep disturbances. And really, milk is important to add protein and calcium that they could be losing. Okay? Oh, there's the drugs right there. So y'all can look at those for yourself. I got ahead of myself. There's the radioactive iodine. Okay, and there's the surgical intervention. Sorry about that. And there's the nutritional support. Okay, I was just looking at my notes and not looking at the PowerPoint I made from my notes. Okay. Nursing care. Of course, you're going to do a cardiovascular assessment. So you're going to notice what rhythm they're in. Let's hope they're in a sinus rhythm, sinus tach, but they could be in a irregular atrial dysfunction. And since you all don't have cardiac yet, I'm not going to hold you to the atrial fib, but you should at least know that they're going to be in a tachycardic state, okay? And all of this is on page 1200. It gives you your nursing assessment with Gordon's functional health patterns, and it gives you nursing implementation on the next 2 pages. So they may need cardiac monitoring. It could be remote monitoring on a telemetry unit or remote on a regular med-surg unit if they are not too sick. If they are in a thyroid storm, where would you expect them to be? What unit would they be on? Yes, yes. Will and Lauren are right. Would be in ICU. What do you expect their temperature to be if they're having a thyroid storm? Yeah, high. And their heart rate? Greater than 100, correct. Correct. So in that situation, you would have, if they were in the ICU, you'd have cardiac monitoring. If they were on the floor, it would be remote. And either place, they have an increased O2 demand because they're in a hypermetabolic state, correct? So would you expect the O2 demands to go up? So here, yes, yes. So you would do adequate oxygenation. So pulse oximetry monitoring is important. Probably need some nasal O2 if they're very bad. And do we need to replace fluid lost from the hypermetabolic demand? Did we say they were in a diaphoretic state? Yes, they are. So we want a calm, quiet room. We don't want to stimulate the fight or flight syndrome, correct, and make things worse because they have this increased beta receptors on the cell that really respond quickly to fight or flight hormones. So we don't want that. We want a cool room. We want to get rid of annoying visitors. We want to be calm and supportive and to decrease any anxiety if at all possible. Now, we need to treat the ex-ophthalmos if that is a problem with this patient. So they have a problem with body image, if they have a goiter, if they have lost a lot of weight. Some people actually do have ex-ophthalmos. So artificial tears are important for this client to maintain moist eyes because you don't want corneal ulcers to develop. You want to gently tape the eyelids closed when they're sleeping at night. Does that make sense? And you may use ointment and tears. You want to have them wear protective glasses when they're up because remember, they don't have a fully protective response with the eyelid closing if something comes near the eye. You want to elevate the head of the bed, and that's around the clock. You want to restrict sodium because remember, they already got a lot of fluid deposit behind that eye. You don't want it any worse, so you're going to decrease sodium. And then attention to grooming to help enhance their body image and support them. Does that make sense about the care that you're going to provide as a nurse? Okay, and there's the artificial tears, the sodium restriction, the elevate the head of the bed, and protective eyewear. Okay. And there's the ICU bed. We already talked about that for a thyrotoxic crisis. Will is very right. I tell you what, I used to close those doors and try to keep it quiet, and then somebody else would start up. And on nights, we turned all the lights down really, really low because we're trying to have quiet. If it was a person who needed absolute quiet, we would try to put them in a corner room as far away from the station, which is hard to do because everything's centered around the station. So alarms going off, things like that, it's just really hard to keep it quiet in the intensive care unit, isn't it? Unfortunately. All right, pre-op interventions, this is for the surgical client. So before surgery, you would teach them, turn and cough and deep breathe. Now, the physician's not going to want them to cough very vigorously because of the risk of hemorrhage, so it'll be minimal, but you could still do incentive spirometer, turning, and deep breathing, and leg exercises. They usually go home the same day. They go home the same day if it's an easy surgery, but most people I know stay overnight and then go home the next day. Remember, if you're giving them SSKI before surgery, what do you remember about the saturated solution of iodine? How would you administer the iodine? Dilute and use a straw, correct. And it can stain their teeth really, really bad. It can irritate the mucous membranes, but they can have beautiful teeth. Now, I'm being sarcastic. The teeth would look really bad. You can teach them simple range of motion of the neck because they're going to do that after surgery. You'll also talk to them about they may have oxygen when they come back. I don't really talk to them about suction because the book mentions that and mentions the trach tray, but you will scare the crap out of the patient if you go into that. I had a relative that looked it all up on the internet and freaked out, and asked me to stay with him during the night, and he kept reaching out and asking me if he's breathing okay, was he having any signs of hemorrhage. He asked me if the trach tray was in the room in case he needed an emergency trach. He was on a regular post-op surgical unit, and he did fine. So he read too much on the internet about the risk of edema in the airway being blocked and the risk of hemorrhage also causing increased congestion in the airway getting blocked. Also, you want to have calcium gluconate available, okay? And then they will teach the patient to support their head manually when they're turning in bed, to minimize stress on the suture line, and practice range of motion exercises of the neck. And then you're going to reiterate all this stuff after surgery. Now, you do need calcium gluconate available for the surgical client post-op. Why do I need calcium gluconate available? And we used to tape it above the bed, but we don't do it anymore. You can quickly get it from the Pyxis if you need it. But why would we need calcium gluconate available for the post-op thyroidectomy client? Okay, what have they possibly nicked when they did the thyroidectomy? They nicked the parathyroid, and then it's not going to produce calcium like it should. Okay, it's not going to respond to the lower levels and keep it maintained by pulling it out of the bone. So you're going to, anymore now, I talked to a thyroid person lately, well, the one that did my sister's surgery. They just proactively put her on an IV calcium chaser post-op. She got 1 or 2, and she went home on Tums, and they said it would regulate itself within a few days. I think she only had to stay on the Tums 2 weeks. But you just want to be aware of that. All right, post-op, you're going to assess for bleeding either anteriorly or posteriorly. And you're also going to be aware of the, and this is on page 1201, be aware of the fact that if hemorrhage does occur, they can have tracheal compression and as a result have problems breathing, neck swallowing. Usually, even with patients who have any type of throat surgery, if you see them swallowing frequently, they're swallowing blood. So you would want to assess for that. You want to keep the head of the bed elevated in a semi-Fowler's position and support the patient's head with pillows. You want to avoid flexion of the neck and any tension on the suture lines. You want to do an initial assessment for signs of tetany secondary to hypoparathyroidism and the loss of calcium. Remember the number 1 complaint they're going to complain of. I know I have Voscheck and Trousseau sign on there, but the number 1 complaint they're going to complain of is numbness around their lips, and that's called a paresthesia, or numbness in their fingers, and that's a paresthesia. That's the early sign of hypocalcemia. Remember, Voscheck is a late sign where they have the Elvis snarl, and Trousseau's is where you put a blood pressure cuff on, and as you pump it up, they have a carpal pedal spasm. That is a late sign. So hopefully it didn't drop that much that you're going to catch it when they start having the numbness. So they need to tell you if they have any numbness or tingling anywhere. And you don't put thoughts in their head and say, well, if you have it in your fingers, tell me, because an older person might say, I do. So just say, let me know if you had any numbness or tingling anywhere. It's important for me to know. And of course, check their vital signs. Pain management, that night they're going to need either an IM injection or an IV medication, but very quickly they can go to Loratabs by the next morning, which is oxycodone, and then they can go, and then they can go home on pain medicine if they need it. Okay? So home care, you're going to assess their body image. It should be on the next page. Related to a neck incision, but you know what? They're so slight, the neck incisions now. They used to be huge. Now they're teeny tiny. They heal regularly. If they have any wrinkles in their neck at all, it's going to cover up that scar eventually. Some people used to be told that they were going to get a pearl necklace as a result. Now they're going to need to know to reduce caloric intake after the surgery because they're not going to have
consumption of all that they take in from a hyperthyroid state, because that's going to be gone. And then you want to assess them for signs and symptoms of hypothyroidism, so you'll teach them those about, weight gain, being very, very tired, of having constipation, the skin being dry. So you're going to teach them those signs and symptoms. They want to do regular exercise, avoid high environmental temps that can cause a trigger that could be problems for them. They need adequate iodine to promote thyroid function, but excesses can inhibit the thyroid gland. So if they want to have seafood, they should only have it once or twice a week. Regular exercise to stimulate the thyroid gland. And you don't want high environmental temps because it'll inhibit the 10% of the thyroid that's left from regenerating. Of course, if they had a complete thyroidectomy, then you're going to talk about the need for lifelong thyroid replacement with levothyroxine, or some people call it Synthroid, and again, teach them the signs and symptoms of hyper and hypothyroidism. Y'all are doing wonderful because nobody's taking a break. Well, that I know of. I know I have not. Okay. Okay. Let me see if there's anything else we want to talk about home care. Just as a rerun, on the surgical client with a thyroidectomy, you assess for risk of bleeding, you assess for edema, difficulty swallowing. If they're hoarse, they're going to be a little hoarse that first night, but they should not have any respiratory distress at all, okay? So now we're going to switch gears and we're going to hypothyroidism, and hopefully that starts on page 1201, and it does, and it goes through 1204. Here you have a common disorder caused by a hypofunction of the gland. It just fails benignly. It can happen as a person ages. We talked about that after age 50. It could be from hyperfunction, where the gland was in a hyperfunctioning state and then the thyroid gland became destroyed and they went into a hypothyroidism. It could be from surgery. It could be from a goiter. So primary hypothyroidism is, do we have that on there or not? No, we don't. So we're not going to, let me go backwards. Okay. We want to go on this screen. Okay. Primary hypothyroidism is destruction of thyroid tissue or defective hormone synthesis. We have secondary, which I think we already talked about that one, pituitary disease with decreased SHH. Okay, we're just going to talk about this. It's rare to see it to be caused from loss of iodine in the United States. So the most common cause of hypothyroidism is atrophy of the gland that occurs with Hashimoto's thyroiditis or Graves' disease, or a result of treatment for hyperthyroidism. Now, if it is a loss of tissue over time, which is a slowing of the body processes, then it's a primary hypothyroidism. It just failed over time, okay? Secondary would be any of those causes from different disorders, okay? But primary is just a benign failure of the thyroid over time, atrophy of the gland. It's a very, very slow process over months to years. A person may not seek attention. They may attribute their symptoms to something else, okay? Now, we also said after thyroidectomy or treatment with antithyroid drugs, they can also develop hypothyroidism, okay? We also said we can give them a radioactive iodine to decrease and throw them into a hypothyroidism state. We mentioned that. Okay, the severity of the symptoms depend on the degree of the deficiency of the gland. So you're going to see long-term effects, most notably in the neurological system, the cardiovascular, the GI tract, the reproductive, and the hematological systems. Neurological, the patient may appear fatigued, lethargic. You know, we said with hyperthyroidism, they were nervous, they were anxious, agitated, I think Will said. Here, the patient may appear fatigued with mental status changes where they're lethargic. They may have slow speech and impaired memory. They may have decreased initiative and just not want to get up and do much of anything, just procrastinate. They may be somnolent where they sleep for long hours, but their sleep is not effective, and they may appear depressed. Cardiovascular hematological effects, we have a slowing of the metabolic function of the body. Everything's slowing down. So the cardiac output is going to be down. They are not going to tolerate exercise very well at all. So they're going to have activity intolerance. They may even tell you, I get short of breath when I do very much exercise. If they already have a pre-existing cardiovascular problem, like heart failure or COPD, then their cardiovascular system is going to decompensate quickly, and they're going to have problems for it. They tend to have a lowered hematocrit. They have a lower EPO levels, which causes anemia, which you'll learn more about EPO being released from the kidney to stimulate the bone marrow to make more red blood cells. You'll hear about that when you get to renals. They have lowered O2 demand. They have vitamin iron deficiency, so they bruise easily. They have elevated triglycerides and cholesterol, which makes them at risk for coronary arteriosclerosis. And hopefully that is in your book, talking about the cholesterol. I just hear, no, it doesn't really, well, it does. Right here it is. Increased serum cholesterol and triglyceride levels in the accumulation of mucopolysaccharides in the intima small blood vessels. Okay. Now, we need to go something even, I hope we're going to get into that. We will. In a minute, we'll get into myxedema. They have decreased GI motility, and we know that that means they're going to have a resulting risk for constipation. They have a decrease in hydrochloric acid being produced by the stomach. So what pH imbalance would they have if their hydrochloric acid's decreased? And you are correct, it's on 1202. Metabolic alkalosis, that's correct. That is correct. So I've got, I believe, some handouts that should be printed. If not, I'll have them printed by tomorrow to give to you guys. I mean, by Friday, of a patient and what they look like with hyper and hypothyroidism. With hypothyroidism, they have cold intolerance, and that should be on the next page. No, it's not. Oh, so we're going to put it on now. Okay. They have cold intolerance. Does that make sense? Because of poor tissue perfusion. Remember, the cardiac output is less. And everything's in a slow metabolic state. So cold intolerance, they just can't get warm. They have hair loss. They have dry, coarse skin, brittle nails. They complain of their throat being sore, muscle weakness. Does their weight go up or down due to the decreased metabolic rate? Goes up, correct. Females have an additional problem. They can have menorrhagia, meaning their menstrual period now really is very bloody, or they can have infertility problems, okay? Now, if they continue with this for a long time, it was missed, you know, that they had hypothyroidism, they could develop a condition called myxedema that's on page 1202. Okay, there it is. And a picture of a person with common features of myxedema is on the bottom of page 1202. They have dull, puffy skin, coarse, sparse hair, periorbital edema, and a prominent tongue. The elderly may have put off seeking treatment and developed this because they attribute their problems to the aging process. They have a mask-like effect on their face. Their mental status can actually progress from lethargic to stuporous to coma, and a myxedema coma is a medical emergency. And it could be that they had a long-standing hypothyroidism that was not diagnosed, and then the myxedema coma is precipitated by an infection, drugs such as downers or narcotics, exposure to cold, or trauma. And they will have, in a myxedema coma, they have acutely low blood pressure, acutely low subnormal temperature, and they hypoventilate, so they breathe very shallow. They can have cardiovascular collapse from the hypoventilation. They can have hypoglycemia, hyponatremia, and so they have to be fully supported and treated in an ICU with IV thyroid hormone replacement therapy, vasopressors, fluid to support them. So it is a medical emergency. Okay, we're getting close to the end. Oh, here's the patient profile that I was talking about a while ago. I had it on a different slide, so you all can look at that for yourselves. All right, diagnostic test. They're going to evaluate the thyroid stimulating hormone. And so what would you expect it to be? Yeah, thyroid stimulating hormone is going to be up. And the free T4 is going to be what? Down. That's correct. Okay. Now, I tried to get this thing off of here and couldn't get it off. But you do the TSH and you do the free T4 to evaluate thyroid function. The serum TSH determines the cause. So if my thyroid stimulating hormone is high, the defect is in the thyroid, okay? And if my thyroid stimulating hormone is low, the problem's in my pituitary gland or hypothalamus, okay, because it's just not releasing it. So what they may do is they may inject a patient to diagnose them. They'll inject them with TRH, okay, the thyroid chronotropic thyroid recepting hormone, which stimulates TSH to be released from the pituitary gland and go to the thyroid. So if we're checking if it's the hypothalamus or the pituitary gland, they'll inject them with TRH, and if their TSH increases, then they know that it's a hypothalamic dysfunction or the anterior pituitary, okay, and not the thyroid gland itself. But we're not going to get into all that nitty-gritty. That's awfully specific. What I want you all to get is the TSH is going to be up and the free T4 is going to be down. Okay, triglycerides and cholesterol are going to be what? Up or down? Going to be up. That is correct. And they're going to have anemia, so we'll look at the hemoglobin hematocrit to evaluate for that. And we can do a lipid profile. And collaborative care, our primary goal is to restore a euthyroid state. So levothyroxine is the generic, levothyroxine, and it is given starting in a average dose and gradually increase in 1 to 4 week intervals, and they increase it slowly, okay? Now, if the person has cardiac problems, you do not want to increase cardiac O2 demand by giving them a lot of thyroid. You're going to go a lot lower with those patients. And don't look at the dosage for a myxedema coma. We know we're going to go higher with those people because they're in a coma. And then just to teach them the importance of lifelong replacement is necessary. And then also you want to assess them and teach them to be aware of subtle changes in their mental status. If they become forgetful, if they start picking up weight, they go back to constipation, it could be they need their Synthroid level increased. Does that make sense? You want to help them to cope with a positive self-image if they have problems from that, and just be very thorough in teaching them the side effects of the medication and not to have anywhere where somebody could get a hold of it like a child and overdose on that. Okay, we got through thyroid and we got through pituitary. We did not touch the adrenals. I do not recall giving you all the adrenal PowerPoint. Did I give you the adrenal PowerPoint? Because we need to start on that tomorrow. Does anybody remember if I gave you the adrenal PowerPoint on Cushing's disorder? And yes, you have it. Good. Okay, good. Okay. All right, so we will, tomorrow we're going to be a little behind because we're hopefully starting on diabetes. But we're going to have the quiz first, and it's going to be worth a maximum of 3 points. And it will not be any select all that apply. I'm sure that will be good news. And not tomorrow, I'm Friday. I'm in clinical tomorrow at Methodist. It's Friday, sorry. Was this helpful today? I know it was kind of fast. We covered a lot of stuff. Yes, and of course it's taped, so you'll have it. And I do have some case studies I need to get typed up either this evening or tonight and put them online for patients with these disorders. Okay, yeah, you can make notes and study and get ahead. And so we will do the quiz tomorrow. Have any questions, you can send them through me to email, and I could address those in class tomorrow. And let me look at one more thing before we stop. I'll be right back. Okay, this is regarding the quiz for tomorrow, because we never did get to go over the questions in the book. Oh, I mean on the test. Number 3 was a high miss, and it was a patient being treated with sulfasalazine for ulcerative colitis. And the major action of that drug was to suppress inflammation, and a lot of people got that one wrong. Number 14 was a high miss. A patient suspected of having colorectal cancer will require which diagnostic study to confirm the diagnosis? And the answer was colonoscopy is the gold standard. Number 26 was a high miss. Let me find it. Okay. That was to evaluate the effectiveness of fluid volume replacement therapy after a burn injury the nurse should monitor for. And here you were monitoring for a urine output of at least 50 milliliters an hour. Number 32. Okay. That was a math question. I'm not sure why number 32. 74% of the class got it right, but 26% of the class got that wrong. That was a math question. I'm not going to give you math in the morning. Number 38 was a high miss. Okay, that was in the emergent resuscitated phase of a burn injury. The nurse should monitor the patient for signs of symptoms of hypovolemic shock, which include, and the right answer there was decreased stroke volume. And 60% of the class did get it, but 40% did not, which concerned me. Because remember, if you're in the emergent resuscitative phase of a burn, you have a problem with fluid movement and hypovolemia. And so if you're going to monitor them for signs and symptoms of hypovolemic shock, you know that the heart is going to pump faster, but each heartbeat will eject less fluid because of decreased volume circulating. So that would be decreased stroke volume. And then number 42, a nurse is preparing a teaching plan for a client with Crohn's disease. Which factor should the nurse include as a possible link? And the answer was hereditary was the answer. And 50% got it right and 50% got it wrong. We know that in any of the GI disturbances, you know, a high-fat diet is a problem. But as a link to development of Crohn's disease, it is genetic. Now, if we were talking about diverticulosis, then we would look at the fat in the diet, okay? Or if we're talking about colorectal cancer. So that was the high misses in the test. So was that helpful to go over that quickly? Okay, all right. Well, you all be safe. Again, it'll be multiple choice questions on Friday worth a max of 3 points. It will be one answer response, no select all that apply, over basic concepts that we covered for the last exam. So y'all have a good day. All right.